Uh, so, I'm just going to discuss briefly about the base of the first metacarpal. I requested Bipin to leave it for me. It's, as Bipin very rightly said, Parag mentioned, it's a saddle type of joint, and that's what makes it a little unique. And when it comes to the first metacarpal, first CMC joint, there are two injuries which we very commonly see in our practice. One is of a Bennett's fracture, which typically is a fracture dislocation. Another is a Rolando type of fracture, which is essentially a TY type of fracture. Both have their own set of problems associated with them. This is example of Bennett's, where you can obviously see there is a tiny fracture fragment to which a very important ligament called the volar beak ligament is attached, and there is subluxation of the base of the first metacarpal. And then you have Rolando, which essentially is an intra-articular fracture. So there are two types of problems that we are dealing with when we are dealing with injuries of the first metacarpal base. One is an articular step, and other is a subluxation. Do we need to give equal attention to both? Can we ignore both? Or can we give more attention to one and ignore the other? That is the crux of my talk today. So when it comes to the Bennett's fracture, the literature says, if you do not reduce the Bennett's fracture well, it's always going to lead to significant amount of arthritis, which is going to be clinically significant. That is the crux of what is written there. So it's easier to listen than to see. So Bennett's fracture, post-traumatic arthritis is almost a rule if you do not reduce them well. Whereas a Rolando fracture, also if not reduced well, will lead to significant amount of arthritis, as much as 55%. However, the symptoms do not correlate to the radiological appearance. So there is something different happening between these two fractures. Something which is different is perhaps the subluxation that accompanies the Bennett's fracture. So probably we are looking at a subluxation with a joint reduction being more important than reduction of the articular step. Now, as Dr. Patankar would agree in one of his cases that he has shown, and even the literature says so, even in the PIP joint fracture dislocations, even if you have an articular step, it is fine. You should not have a joint subluxation. As long as you have a congruous joint with an articular step, it's still going to do well. One of the reasons why the CMC joint is so unforgiving is, say if you take an example of, say, a radiocarpal joint or any ball and socket joint, so with little bit of malalignment, there's still fair bit of congruence that is maintained in the joint. It's like a round spoon in a round spoon. Whereas when you have a saddle type of joint, that the first CMC joint, it is like your tablespoon in a tablespoon, where slightest malalignment and you start getting point loading in the joint. Same is true for a radioscaphoid joint in the wrist. Slightest malalignment, point loading starts happening and you start developing early arthritis. Therein probably lies the need for reducing the subluxations very aggressively. A few things about the thumb CMC, which are very beautifully described in this book by Paul Brand, Biomechanics of the Hand. It's a beautiful book to read. It's almost a novel to read. It says that the base of the first metacarpal, the first CMC joint, is a twisted hinge with all three axes are tipped. Now, whatever it means, I will explain to you what it means. What it means is any movement in the thumb is not an isolated movement. It is always a combination of the three axes, the flexion extension axis, the adduction abduction axis, and the internal and external rotation axis. There is no pure movement in the thumb. One of the reasons why it happens is each motor that acts on the thumb metacarpal will have effect on all three movements. There is no pure flexor, there is no pure abductor, and there is no pure, which one? The rotator. So this is a simple hinge where one motor acting will give rise to one movement. The axis is perfectly aligned. The moment this hinge is tilted, now one motor will start giving two types of movements. Now, if this same hinge is tilted in the third axis also, one motor will give you a combination of three movements, and that is exactly what happens in the thumb. thumb has been designed in such a way that with least number of motors acting on a very small area, you have a fantastic degree of range of motion available at the CMC joint. And that is what also makes this joint more vulnerable to early arthritis, and therefore joint congruence becomes important. Even in a non-traumatic situation, then this is an extra-articular fracture, or even in a non-traumatic situation, the CMC joint keeps rotating around the volar beak ligament that I mentioned to you about. And the forces acting on the CMC joint are quite huge. Any pinch force that you apply, 10 times more force is acting on the CMC joint, and over a period of time, this volar beak ligament is going to get stretched, and the joint starts subluxating laterally. And as we know from whatever blah 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 discussion that we had before, slightest subluxation and the joint will start developing arthritis because of whatever mechanics we discussed till now. And therefore, in order to get a good outcome from the first CMC joint, the joint reduction, I am not talking about the articular step, I am talking about the subluxation of the CMC joint, has to be predictably and stably reduced and allowed to heal well in that position, and that should be the crux of our treatment. So just a few examples. This is a Bennett's fracture, a very simple method of fixation, close reduction by whichever maneuver. Because the wires are holding it, as you can see, the MCP joint has gone in extension. That ideally should not happen. If you are treating this without K wires, then this hyperextension should ideally be here, but since you are holding it with a wire, it would not matter much. A very simple method of treatment. This is another variety, highly unstable fracture. This was an orthopedic surgeon, wanted to get him mobile early, not a very easy fracture to reduce. From the quality of reduction you can see, but since this was extra-articular, I just wanted to get stable fixation of the metacarpal and got moving early. This is a Rolando fracture. I think Rolando fracture is perhaps the easiest of the lot to treat. And you can treat it by a variety of methods. You can use percutaneous K wires, you can use a fixator, you can use a plaster, you can use a plate and get them mobile early. Now, this is another Bennett's fracture which was treated. You can see it was treated with K wires and patient continued to have pain. I attributed pain to two reasons. One was a step off and a subluxation. Given an opportunity, I would want to correct both. I did not want to take a chance. This was a young chap. So not only did I do an open reduction for this, but I also tried to reduce the stretch on the volar beak ligament and reduce the joint and just supplemented with a what is called as a tightrope. You could use anything. You can use a tendon graft to pull the metacarpal base into reduction. Important thing is to hold it in reduction predictably till the soft tissue healing would happen. And that's the AP view. And the last one, this was a young lady, particularly prone to injuries. You can see she already had one injury fixed in the past, had a CMC dislocation. This is Dr. Mutha's case. Thanks, Satish. And then we fixed it using a CMC tightrope. Not only that, we also did tightening of the capsule for this and allowed her to heal in that position. And at 3 months, she remained reduced. So the take-home point for the CMC joint is pay particular attention to the subluxation and be very aggressive about reduction of this subluxation. It's much easier to treat the subluxation while it is acute than to treat the arthritis of it. Thank you very much.